Dr. J. Mathew Perumal, who is the medical director at Dr. Agarwal's Hospital, Trivandrum, to deliver his first talk on glaucoma emergencies, where every millimeter of mercury pressure counts.
Good afternoon, everybody. As Dr. Sharat said, the first topic in this course on ocular emergencies is acute glaucoma, where when every millimeter of mercury counts. So, during our studies and all, an acute glaucoma is something which is, drummed into us. We're very frightened of it. So, according to the American Red Cross, in any emergency, forget about ophthalmic emergency, these are the 4 things you should think about. First is stay calm, assess the situation, call for help if needed, and then provide basic care. So using that template in this case, so when a patient comes with a suspected acute glaucoma, what do? First you stay calm, then you assess the situation in detail. What is the cause for the acute glaucoma? Is the angle open or closed? Then you reduce the IOP, then you treat the underlying cause, which is probably the cause to increase the pressure in the first place. So when you talk about acute glaucoma, you can broadly divide it into 2 groups, like you have a primary angle closure glaucoma, then you have secondary glaucomas. Under primary angle closure glaucoma is the dreaded primary acute angle closure attack, as well as primary angle closure glaucoma. And under secondary glaucomas, which a lot of we see daily in our OPDs, is you can have either a secondary angle closure glaucoma or a secondary open angle glaucoma, under which these different conditions come, which I'll go through in detail down the line. So an acute angle closure glaucoma basically is due to its excessive iris lens apposition, which impedes the flow and of aqueous humor, and it causes a relative pupillary block. So the pupillary block is the reason causing this pushing forward of the iris, and because of this resultant pressure gradient, the peripheral iris bows forward and blocks the trabecular meshwork, leading to an elevation in intraocular pressure. So the patient usually comes with an acute onset of elevated intraocular pressure. When you do gonioscopy, the angles will be closed. There will be a shallow anterior chamber. The fellow eye, incidentally, will also have a narrow angle as well. The patient will be in some distress. The conjunctiva will be hyperemic. The pupil will usually be mid-dilated and non-reactive. The cornea may be cloudy. The pressure is very high. Vision will be reduced. Patient may complain of other visual symptoms. And pain is the main thing. The patient will be in some amount of pain. And if the pressure is very high and the patient is quite distressed, they will have additional autonomic symptoms like vomiting, nausea, and other symptoms at all. On taking the history, if possible, you might find a history of previous similar attacks which were ignored or not properly treated. And basically, when you see these patients, they'll have a similar sort of morphology where a small anterior segment, usually hyperopic, small cornea, and a small anterior chamber depth due to either a large lens. So this is what usually they come with, like, a steamy cornea with flushed eyes. So how do you manage a acute angle closure? So if you look at it in this way, basically medically and the other way. Medically is first is try to reduce the IOP. Either you give pilocarpine to break the pupillary block, as well as topical beta blocker. Sometimes if the cornea is quite edematous, pilocarpine might not act. So to reduce the pressure first, you have to usually give intravenous mannitol along with orlasterzolamide. Once the block breaks, immediately you will have change in this, where you'll show a deepening of the chamber. The pupil starts constricting, which shows once the break comes, the pressure starts reducing. In a very early case of acute angle closure, sometimes even with an indentation gonioscopy, you can break the block. But finally, you will have to end up doing a iridotomy, either laser or surgical. Laser iridotomy is the mainstay. If you can do it properly, that will help. And of course, don't forget, a prophylactic laser iridotomy is a must. So now if a patient has an acute angle closure attack in one eye, the fellow eye is at 80% risk of developing another attack within 5 years. So in that case, if the patient has acute attack, once you do in the other eye also has to have a laser iridotomy. Other cases where you suspect the patient may go into this when you do a routine gonioscopy in the OPD. Any synechia, if you see in the angle, appositional closure more than 180 degrees, strong family history, it's very common. You'll see the family history of angle closure, shallow anterior chamber is there. Certain medications can precipitate an angle closure attack. And then, of course, chronic angle closure, also called creeping angle closure. If you suspect a creeping angle closure, whereas small synechial closure, progressive, if you do a iridotomy early enough, you can prevent further progression of the disease and then the invariable treatment of glaucoma. Then that is how you challenge an acute primary angle glaucoma. Then comes the secondary angle closure glaucomas. In the secondary glaucomas, you have angle closure and open. Many of these conditions are like they can come present in either way also. So if it's a secondary angle closure glaucoma, there are a few ways in this, because there is a what you call a physical aspect to this. There is the pupillary block which can happen. Either the pupil gets secluded, there could be some displacement of the lens, or peripheral anterior synechia. All these systems act in concert, which can cause a secondary angle closure. If there is a pupillary block, or if there is a risk of a pupillary block, iridotomy will definitely help. But if the basic cause, there is no pupillary block, maybe there's no point in giving a PI. So what are these causes? Like I said earlier, the pupillary block, all these things. Some of these conditions are rubeosus iridis, ciliary swellings and posterior segment tumors, lens-induced condition, posterior synechia, malignant glaucoma, and eye syndrome. Any of these cases can cause a secondary angle closure at the angle level or at other levels, causing the glaucoma to rise. So I'll just touch on a few things. Malignant glaucoma, also known as aqueous misdirection. Commonly we see it after filtering surgery, even sometimes otherwise also. It's a pretty rare combination, but you'll have a flat anterior chamber with elevated intraocular pressure, even in the presence of a patent iridectomy. So this is due to the misdirection of the aqueous, where the aqueous is directed into the vitreous cavity and causes into the area and causes pockets in the vitreous and forces forward the iris lens diaphragm. So in smaller eyes also is common. So once you see this, usually it's a bit counterintuitive. You have to do medical treatment. It works in around 50% of the patients. Immediately administer systemic hyperosmotic agent like mannitol, and then you do a maximal mydriasis with cycloplegic, which will hopefully prevent hopefully cause a rotation of the ciliary processes, preventing the aqueous misdirection into the vitreous. And then, of course, the other anti-glaucoma medication, usually topical beta blockers and acetazolamide. If it's a pseudophakic patient, you can do an anterior hyaloid disruption using YAG. If you break the anterior vitreous face with the YAG laser, sometimes you can relieve some of the pressure from behind. Otherwise, usually a very effective this thing is a pars plana vitrectomy. Once you remove all the fluid and the vitreous, that will relieve the condition. Then coming to secondary open angle glaucomas, pigmentary glaucoma, pseudoexfoliation glaucoma, and steroid-induced glaucomas also can cause this thing, but these are all treated like an open angle glaucoma or whatever. You treat it in that way and reduce. In case in a steroid-induced glaucoma, once you stop the steroid, the pressure immediately comes down, and you can continue anti-glaucoma treatment till it reduces. Then neovascular glaucoma, uveitic, and ocular trauma. So coming to the lens-induced glaucoma, again, like I said, you can have an open angle or closed angle, whether it's a phacolytic or a phacomorphic glaucoma, or even retained lens material after surgery. Most of these secondary glaucomas, once you treat the basic cause, that will usually help you reduce the condition. So neovascular glaucoma is a very common one we see in our OPs, where due to rubeosis and angle neovascularization, initially it will have an open angle, but as the neovascularization progresses, it can lead to closure. Always look for NVI at the pupillary margin, where if you look at high magnification, you can catch it very early. And invariably it will be due to retinal occlusive vasculopathies like diabetic retinopathy or CRVO. The treatment of the retinal ischemia with a pan-retinal photocoagulation with and anti-glaucoma, and of course steroids and atropine. Neovascular glaucoma is quite difficult to treat, and it requires a very aggressive treatment, and then you might even end up doing a cyclophotocoagulation, vitrectomy or filtration surgery as well. So I'll just quickly, the same thing with the uveitic glaucoma and the ocular trauma. So treat the cause, and basically good laser iridotomy has to be done, and the procedure with put topical pilocarpine, use a lens and put iridotomy in the superior iris, laser settings between 2 and 6. In cases where you cannot do laser iridotomy, you can do a surgical iridectomy. Basically reduce the pressure, and that will take care of this thing. Thank you.
Thank you, Jay, for your talk. I'd like to ask a question. In a post-vitrectomy scenario, when you have a raised IOP, either because of a silicon oil tamponade or a gas tamponade, which agent do you prefer to start your treatment on?
Agent as in medication?
Medication.
Yeah, so most of these cases you have a choice of anti-glaucoma medications, but prostaglandins, although we use it regularly in this thing, can cause inflammation. So we prefer to use topical beta blockers or carbonic anhydrase inhibitors, or even brimonidine first, and then, like in this case, if it's an angle closure, we have to do a PI. As you know, if you have silicon oil, you do inferior PI. But medical treatment usually takes care of it.
Okay. Thank you.